You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 13th, 2017. This week, the evaluation of chest pain, the prevalence of obesity worldwide, the effect of weight and blood pressure, the cost of cardiac device recalls, and two interesting studies about the effects of NOACs. Now, first up is the evaluation of patients with chest pain. And before I start, you need to know that I was a co-author of this systematic review and meta-analysis along with Andrew Foy and other authors. Millions of patients are seen for chest pain, and one of the chief concerns, obviously, is coronary heart disease. CCTA, or coronary CTA exams, have emerged as a new approach for the diagnosis of anatomical coronary disease. It's unclear how an anatomic strategy, though, matches up against the standard functional stress testing with typical stress test. It turns out that there have been numerous RCTs, randomized controlled trials, that have looked at this question. Our paper was a meta-analysis and systematic review of these studies. Our outcomes were all-cause mortality, rehospitalization, MI, invasive studies including revascularization, and the new diagnosis of CAD, or change in prescriptions for aspirin and statins. We found 13 trials that qualified in about 10,000 patients in each arm. The tests were CCTA versus functional stress testing, and the mean duration of follow-up was about a year and a half. And our main findings were that CCTA made more diagnoses than functional stress testing, almost by a factor of 3. The risk ratio was 2.8. CCTA also led to more cardiac procedures and more revascularizations, but get this, no differences in death or hospital readmissions. The patients evaluated with CCTA did have a slight reduction in the incidence of myocardial infarction, but it was 0.7% in the CCTA arm versus 1.1% for the functional stress testing arm, and here the relative rate was 0.71, absolute difference only 0.4. And the patients in the CCTA arm had more use of aspirin and more use of statins. The key caveat on that MI signal, though, was that most of the 0.4% absolute risk reduction was driven by only one trial, and that was the Scott-Hart trial. The Scott-Hart trial compares CCTA plus functional stress testing with functional stress testing alone, and thus it was an outlier. And it was an outlier because it did not directly compare CCTA versus functional stress testing. Even with the MI signal, the take-home is not changed. That is, anatomical testing identifies more disease, but because these patients had normal enzymes and non-ischemic ECGs, the CCTA results in overdiagnosis. And overdiagnosis is good for doctors, it's good for hospital because it leads to more procedures. But the extra diagnoses and interventions does not lead to a reduction in mortality or hospital readmissions. And this we could predict from the COURAGE trial. And COURAGE showed that PCI plus medical therapy did not improve outcomes over medical therapy alone in patients with stable coronary artery disease. And even if the MI signal in our meta-analysis is real, which is unlikely to be, the tiny benefits do not justify the extra procedures and cost. Functional stress testing alone, in my opinion, should remain the go-to test for low-risk patients with chest pain. And these findings harken back to something we all learned a long time ago in training, and that is that having coronary atherosclerosis, or the presence of disease, is not the same thing as having active coronary ischemia due to ulcerated plaques. Invasive approaches in patients with STEMI and high-risk non-STEMI improves outcomes. But testing like CCTA that leads to interventions and invasive approaches in patients with stable arteriosclerosis will not improve outcomes, and that's exactly what this systematic review and meta-analysis showed. Next topic is obesity. This past Wednesday was World Obesity Day, and a stunning study in Lancet revealed a 10-fold higher number of overweight and obese young people over the last 4 decades. 10-fold increase, and these are young people. Now, this massive study of worldwide trends puts numbers to what we see every day in the United States, but we've come to ignore it or see it as normal, namely that we don't even seem to notice obesity as an epidemic. Now, get this. In the U.S., almost 1 in 5 children or adolescents is obese and more than 4 in 10 are overweight. We have a news story on this study, and I wrote a column on how physicians can help and maybe even help the public's health. The teaser is that I think clinicians, and me included, default too quickly to medications and procedures in the treatment of patients with obesity. We don't notice the obesity and we don't focus as much on that because that's harder to do than to write a prescription. And this study reinforces my bias on this next study. And this next study is on weight and blood pressure effects. I often tell patients with atrial fibrillation and high blood pressure that these conditions are unnecessary. Weight loss can reduce blood pressure and AFib. An observational analysis presented in abstract form at an AHA council meeting supports the weight-blood pressure connection. This study tried to tease out the role of being overweight as a young person and then having hypertension in middle age. Now, these sorts of questions are usually answered with longitudinal studies in which people are followed over decades. This particular longitudinal study used data from the CARDIA, coronary artery risk development in young adults. It was about 4,600 participants. Now, obviously, many metabolic risk factors, including smoking and alcohol use, play into the development of developing high blood pressure later. But the novel finding of this study was that weight played the biggest role. Specifically, those who maintained optimal body weight were 41% less likely to have increasing blood pressure as they aged. Maintaining physical activity and a healthy diet were not associated with future changes in blood pressure. Now, that's not to say that other healthy living habits like not smoking aren't important. Of course they're important, but for preventing high blood pressure and probably atrial fibrillation as well, staying lean is key. Next topic is cardiac device recalls. The OIG, or Office of Inspector General, a government watchdog group, published a provocative report on the matter of increased costs from cardiac device recalls and premature failures. This report did not mention the names, but it basically did a statistical estimate of what these device recalls cost using claims data on the 7 devices that have recalls and premature battery depletions. Now, any of us in the EP community would recognize these devices. The excess cost, upwards of $1.5 billion, weren't the only point of this report, though. The other aspect was on how hard it is to track these failures, and the difficulty tracking may impair patient safety because it delays finding out about these safety issues. The reason this makes the podcast is that the scope of this problem, I think, flies under the radar of the average doctor and patient. Now, the absolute numbers of device recalls divided by the huge number of device implants means the chance of having this happen to you or your patient is pretty low. But, as mathematician Nassim Taleb teaches in his book Anti-Fragile, which I am reading, the downside risk is immense. And I say that because the risk from a device revision or extraction is significant and in many cases greater than de novo implants. So yes, we certainly need better means of post-market surveillance, and I actually think there is probably better post-market surveillance now than there used to be. Last topic concerns NOAC effects and NOAC interactions. 2 recent studies in JAMA highlight important clinical issues that we see almost everyday issues. Now, one was a retrospective cohort study using a large Taiwanese database, and these researchers were looking to associate bleeding with certain drug-drug interactions when taken with the NOAC, or new oral anticoagulant drugs. Their study included 91,000 patients. The mean age was 75 years, and they looked at 12 specific drugs taken in combination with NOACs. And they found that the 3 most commonly encountered that increased bleeding rates were amiodarone, a rate ratio of 1.37, fluconazole, with double the risk of bleeding, 2.35, and phenytoin, 1.94. Interestingly, common drugs that could have increased bleeding based on the PGP and CYP3A4 actions, but did not, were atorvastatin, digoxin, diltiazem, verapamil, and jonetarone. The point here is to really pay attention to drug-drug interactions with the NOAC. I don't use a lot of amiodarone for atrial fibrillation, but it's used in the community quite often. The next study on NOACs was one that looked at hematuria. Now, hardly a week goes by when I don't get a call from a patient or urologist about blood in the urine while a patient is taking anticoagulants. Now, probably this happens to you as well. A huge population-based observational study from Ontario, Canada confirmed the use of any antithrombotic medications, antiplatelets or anticoagulants, compared with non-use of these medications, associated with higher rates of hematuria complications. And this included ER visits, hospitalizations, and even urologic procedures to manage the hematuria. The researchers also found that the rates of hematuria were higher with anticoagulants than with antiplatelets, and patients taking any antithrombotic agents were more likely to be diagnosed with bladder cancer, which is probably an unmasking effect. I've seen this unmasking effect with colon cancers as well. And of course, the key point is that hematuria should not be blown off just because the patient is on antithrombotic drugs. It almost always implies some pathology. I like to tell patients that anticoagulation at normal doses almost never causes bleeding, but rather enhances bleeding that is there for another reason. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. See you again next week. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.